to our second session. It's a case discussion on CIN management. Let's call in our experts. Dr.Priya Ganeshkumar ma'am, the backbone of this series, which is happening thanks to her initiative and enthusiasm. She is renowned in the field of preventive gynae-onco and is an IFCPC and FOXY colposcopy course trainer. Dr. Bharti Rajshekar ma'am, she is chairperson FOXY Perinatology Committee and immediate past president Kasoga. Dr. Sundari ma'am, she is retired professor at MS Ramaya Medical College and consultant gynecologist at Ramaya Hospital with a keen interest in preventive oncology and teaching. And Dr. Vidya Tobi ma'am, she is ex-HOD Alamin Medical College, Vice President FOXY 2025 and past President Kasoga 2023. Over to Priya Ganeshkumar ma'am for proceeding with the session.
Dr. Bharti is unable to open her camera. Kindly please help her, Rashmi.
Yes, doctor, we are on it.
Yeah, please. So after this fantastic, intriguing session 1, which we had, now we are going on to one case-based discussion, and we have with us all the wonderful, the experts in this field. And the purpose of bringing this case-based make only one case. We're going to talk about it. We're going to talk about the common practices which is happening and which we really want somehow to, we've been hitting our heads time and again to understand what should we do. It's all very, very common case. Nothing very important, very major case. Every gynecologist has this type of cases. And in our practice, almost 70% of our cases are white discharge leukorrhea. So Dr. Sundari madam is there with us, Dr. Bharti is there with us, Dr. Vidya is there, and we will be taking insights from our experts. So I'll just talk about this case quickly. That it's a 42-year-old female. She comes with a white discharge. It's non-foul smelling. It's no pruritus. There's off and on pruritus, and that's it. No dyspareunia, nothing. But she is having a white discharge. She has gone to various doctors for it. Many doctors have given pessaries, and she's taken many of the, oral tablets and vaginal pessaries and everything. But her menstrual history has been regular and normal. She's got 2 FTNDs. There has been no abortions and nothing. So I want to have our now panelists, like our experts. Sundari madam, this type of cases on and off we are getting. What do you think, ma'am, should be our way of approach? Sundari madam? Not able to hear you, ma'am. Your mic is off, I think.
She has to unmute.
You have to unmute, ma'am.
No, am I
yes, ma'am.
now?
Yes, ma'am. Now we can hear.
Sorry. Okay.
Yes.
Okay, that is a screening has to be done. Okay. For the cervical cancer screening, we have to do 42 years. I don't know whether she had screening. That was not mentioned in that.
There was no screening done prior, ma'am. She just entered into the clinic and that's it.
Okay, she has never had a screening, so it's obvious that we need to do a screening. Now here, what is if her affordability is there, we do co-testing right away. If she is not affordable, we do a liquid-based cytology or even a conventional pap smear is also okay. We are worried about high-grade lesions. For that, conventional or a liquid-based is equal sensitivity and specificity. Whatever is available, we have to do that. Then we go further.
Yeah. So in this case, madam, I think I just stop sharing my screen.
Yeah, two devices.
So here we have now. Here we did her. She is little affordable, and we got her HPV done. And this was her HPV 129.8 positive, and genotype was non-1618 positive.
That is echoing.
Dr. Priya, I think 2 systems are open.
Two systems have been open, Priya. Your voice is recurring.
Yeah, I saw that. But I don't know. It's my one system only. So, madam, with this type of... Oh, no, this is... Yeah. Just a minute. So, what do I do? So, we can actually discuss because my voice is echoing and there is certain problem with this. So quickly, I'll just show the case, and then I can stop the this thing recording, thing, and then we can just talk. So this was what had happened was LBC came up to be HSIL. We'll just take up this case and quickly then I stop and then we can have a proper discussion. Now, this was her colposcopy because of the HSIL and because of the genotyping non-1618 and PAP being HSIL. And a colposcopy was done. I'm going to, Madam Sundari, Madam and Bharti and everyone, we have seen this case. Because of my voice getting echoed, I'm just now going to quickly show this colposcopy. And then we are going to discuss on how these type of cases can be easily missed out. So here was a case where there is a acetovite area. Punch has been taken, which is LCIL, CIN1. But her sweeting out over here has been 1 + 1 + 1 + 2 + 1. That is an endocervical lesion. And sweet scoring is very important for us to make us understand the subject well. I brought this case purposely because many a times these lesions are missed out on our colposcopy. And having the sweet 6 makes us understand that this is a high-grade lesion. And so we have to be more categoric on understanding. So when I did a biopsy, it came up as CIN1, which was discordant to what our colposcopic finding was. Whenever there is such thing, then I went ahead doing a LETS. And I got this thing of CIN2, which was again a concordance with the PAP and sweet scoring. And now with this, I'm going to stop this and we are going to have a proper discussion so that there's no echoing now. Okay. But still, I think, do we have any, are we having this echoing coming up? Still?
Yes. It's still echoing. Yeah, it's still echoing.
Okay. So Sundari Madam, Dr. Bharti, your expert opinion on this? Sundari Madam, Dr. Bharti, how do we have to take up these cases? How are we planning to take these cases? It is for the general gynecologist, Madam. Yeah.
Doctor, can you unmute yourself?
You have to unmute, ma'am.
Hello?
Yes.
Hello? Rashmi,
Yes,
all the
doctor.
time it's getting muted. I don't know why. I'm not muting it, but it's automatically getting muted.
You can go ahead, doctor.
Yes. There is echoing
is
for
again
everybody, I think.
There is echoing, no? Okay.
No, ma'am.
Okay. About this particular case, you want me to talk about it,
And
right?
also for generally, for the doctors, we really want to give them a good message, ma'am. How to go about with such type of cases which is coming up.
That means when there is a discordancy, what to do, is it?
Yes.
See, you have got a colposcopy done for her and the pap smear. Pap smear is HSIL. Colposcopy is low-grade lesion. It looked like colposcopy biopsy. That's the time when you have this, even though transformation is type 1, you have to do endocervical curettage first. Okay, Priya? So when we do endocervical curettage and the lesion maybe, especially she's 45 years, maybe it is a transformation zone. I mean, type of transformation, maybe type 2, it could have been also. I don't know what is the type of transformation.
Here the transformation zone was type 3. Completely it has gone inside.
Definitely, then you have to go for an endocervical curettage.
Absolutely.
That would have given you the positivity, I mean, correlating with your HSIL. So it's on the ectocervix, we have done it is CIN1. But when the type 3 transformation zone, compulsorily we have to, even we may not do ectocervical biopsy because it's no lesion is there or a very minute. You think that it's a sweet score is something less. But you said here the sweet score also is 6 or 7 on the ectocervix also. That means it's extending lesion into the canal. So you have to do along with that ECC. That will tell us the discordancy or cordancy, you can get it done. Even with that, there is a discordancy. Always we are worried about even in one report when it gives a higher grade lesion. So we can't neglect it.
Absolutely.
Provided your cytologist is very good, because The cytology can be HSIL, LSIL. I have been saying in my practice, it will come as they will give us HSIL, and when I go in and do everything in colposcopy, there will be nothing. You follow them up, they are okay. And after some time you repeat, it will come in another lab, or you send the same slide to other expert whom you believe, it comes as LSI. This is happening to me. So that is other thing you have to think of when cytology is being an objective type of reporting. Each cytologist will report in a different way. So that also you have to keep up before jumping into a procedure like a leap or a cone or something. That's the way I do it.
Yeah. So Dr. Bharti, you've been doing lot of screening. I know in your area, and you've been very active with vaccinations and screening and this topic. You would have also seen such type of cases, and these are the cases which normal gynecologist also sees. And many, many times in our practice, we are very busy with our other factors that we do miss out many things. We don't go ponder into taking up an HPV. Now here her HPV was with hybrid capture. Now the hybrid capture had shown a very high figure of 221. Now that means this RLU, when to make you all understand what hybrid capture it is and what genotype is and what HPV is for that matter, how an HPV test has to be taken up. An HPV test is, as WHO says, take it up as a first line also, primary screening. If you can do with HPV, you have to have the validated test in the first order. So having a hybrid capture, I purposely bought this case because hybrid capture makes you understand the copy number. So more than one relative light unit, RLU itself is positive. Now, this is a clinically validated test, which gives you an understanding that denominator is 5,000 and above whatever comes is given as 1. So it's a ratio, relative light unit. It talks about 13 high risk strains, but it doesn't give us genotyping. So whenever you would have done, suppose there are various ways which our gynecologists are doing these days. What they are doing, a case comes to them, either the PS examination. Many people aren't even doing a PS examination. Bharti, do you want to talk on that? It's so important.
Oh, yes, definitely. Yeah. So initially, thank you, Dr. Priya, for having us on this excellent webinar, and the previous Dr. Girija did a wonderful job. Namaste, Sundari Madam, for being here.
Namaste,
And I think the basic thing every gynecologist has to do, irrespective of whatever she may come, I think a speculum examination is what we have to do first, because we may be doing the HPV hybrid capture test, but that does not say that we don't do, of course, we will, if you're doing the HPV test, we are going to do a speculum examination unless it is a self-testing modality. For example, just today I had a lady, a postmenopausal woman who has got a very very confusing reports from previous gynecologists. They have done a pap smear because she went with postmenopausal bleeding. First pap smear comes as HSIL, and then the gynecologist was confused as what we've done. They have repeated it, and it has come as LSIL. Then they were referred to me for colposcopy. And so when I did the colposcopy, she was a SWADE score which was less than 3. However, there was a small endometrial, a small polyp-like tissue lesion was there. And I also did an endometrial biopsy under hysteroscopic guidance for her, and she had an endometrial polyp also. And so the bleeding probably was not from the cervix, but it was coming from the endometrial polyp.
Absolutely.
So, and they were worried because the report came as HSIL, and they said this is pre-malignant, you have to undergo a hysterectomy. So I think in such cases, we have to be very, very prudent in our clinical examination. One, two, first history, then the clinical examination. And then, especially if we come with postmenopausal bleeding, we can't just do a HPV test or a pap smear and go with just that one report. We'll also have to do an endometrial sampling, ideally a hysteroscopic examination. So clinical examination, then do the HPV. Routinely, if they come to you, we do routine HPV testing for all women above 30 years when they come. I give them awareness, and if they're not able to do it at that sitting, they come back for the next sitting. And if the HPV capture, low risk, there's no positivity, there's low risk. We ask her to come back for 5 years, but I tell her to come back next year for a speculum examination, not for a HPV test. I am going to do a speculum examination after a year for some other lesions she may get. And allow, she may be having some other uterine abnormality, though she's normal. But if the HPV test comes positive, here is the glitch that most of our regular gynecologists are facing. What next?
Correct.
Because many
Absolutely.
are not colposcopically trained with colposcopy. So the head still comes, they will say hysterectomy. So I think this is where we have to say triaging is necessary. You do your HPV test, it comes positive, or there is a lesion and the HPV test may be negative. Please advise a colposcopy for them.
Correct.
One
And
even
in your case, Dr. Bharti, you just mentioned post-menopausal bleeding or spotting. So it's very, very important to understand that as per these guidelines of ASCP guidelines 2019, it had a risk stratification symptoms for doing a colposcopy. So initially in 2012 and all, we used to talk about screen positives go for colposcopy. Now we are also saying that postmenopausal bleeding, intermenstrual bleeding, postcoital bleeding, repeated white discharge. It means like 3 to 4 times she's having white discharge. And it's not getting treated. I mean, she's gone to a number of doctors. She's, in spite of taking tablets, she's not getting the relief. And unhealthy cervix.
yes.
Even though the screen might be negative, I've seen a number of cases in my lifetime where the screens were negative, as Sundari madam just mentioned. That could have been, or you also mentioned, like, one was HSL, one was LSL. How do we then understand that are in the same lab, in the same thing? This is where symptoms, per speculum examination, understanding the cervix truly, truly, truly comes into the play. And when you do a colposcopy, do a scoring. I have seen cases coming from Pan India where only photos are there. The photos are taken to go ahead doing a hysterectomy. So let's dissuade ourselves. Colposcopy is a brilliant tool, absolutely brilliant tool to understand the cervix. If you're not a colposcopist, not that everyone are colposcopists, not that everyone knows colposcopy reading, this type of high-risk cases, please refer to colposcopy is number one. We do have these days AI-based, mobile ODT like
Mobile devices.
like GenWorks has got his mobile ODT. So in this, the AI based is there. Now having this type of tool in the clinic, in your facility, truly helps. I mean, you
Yes.
looking at directly and then doing a VIA, might be sometimes a shadow comes. You're missing out so many lesions if you're not proficient enough to do a VIA. Even when I say VIA, VIA also requires its own understanding. Otherwise, many times, Madam Sundari Madam is over here. She has been the doyen of screening in Karnataka. Ma'am, you will agree with me
Yes.
that many a times false VI positives.
Yeah. Yeah, many a time. It has got
So
its own
that's why-
limitations.
Its own
No,
limitations.
it's not a false VI, but you must be, as you are telling both of you, clinical examination, you have to get oriented how thick acetovite is a thick and pathological when you do VIA, Priya. If you know that, see what happens is even in a metaplastic epithelium takes up the acetic acid to a certain extent, is it not?
That is
So many
physiological.
things. So that time you as you go on seeing it, you will understand, oh, this is pathological, this is, you will be able to discriminate that. So that
Correct.
is what we wanted. And one more thing in a Bharti's point, can I or you want to finish? Yeah.
No, ma'am. No,
Finish,
this
Priya.
is a
Yes,
open
One more
discussion.
thing
Yes,
I
ma'am.
just wanted to tell you is, please, we have to understand something is HPV DNA testing and the cytology abnormality, what you get are not equal. I always teach my student HPV DNA testing means what? It is a serological test. It means she is harboring HPV DNA virus. That doesn't equal to cytological changes in the cervical cells. It may not bring also the cells. She may be, because now I have a great problem in the villages because Indian Cancer Society is associated with me in Karnataka. They are bringing only HPV DNA testing. That to COBAS, we are doing it. Every patient, every camp, when I do about 25, 30, believe me, 6 are positive HPV DNA. It's a mammoth task to bring all of them for colposcopy because I have to do either they are 16 or 18 positive. One more thing is if it is not 16, 18 positive, we can postpone our colposcopy and we can do a PAP and then we can call them back after 6 months. That's number one. If it is 16 and 18, definitely it warrants immaterial of our cytological report. It warrants for a colposcopy. These are few things we have to remember as a practitioners. Now, HPV DNA can be positive, but she may not become cytologically abnormal even forever. After 2 years, you repeat HPV DNA, she may be negative because it takes 1 to 2 years is a transitory period for HPV to spontaneous regression or resolution of the infection. So we may have to wait for that. So HPV DNA is positive means even 16, 18. It doesn't mean that she has to be positive cytologically. And it is proved in the villages now, many of them are HPV DNA positive, but none of them is positive colposcopically. Even sometimes because it's 16, 18, you know, though it is so much of experience, sometimes it breaks your head. So take a small biopsy, even a very thin aceto-white, non-specuous aceto-white also, you take a biopsy, it comes as cervicitis. So I have been going through for the last 2 years this. So please understand HPV DNA matlab, it is she has infection, she has a potential to go through for the abnormalities or a pre-malignant lesions in the cervix. It is not equal to having a cancer or a pre-malignant lesion. That's the other thing people have to remember. Only thing it says to us is she needs a close surveillance. How close is the surveillance? If pap smear is negative, we know after 1 year we call them. And Priya was talking about ASCP risk scoring. I mean, that if you can download and keep the app with us in our mobiles, it's very useful. I tried, but I'm not able to download it. But say what it says is mainly depends on previous HPV test results and PAP results. That's all it talks about. Depending on that and the prayer, now presently, what is that? Correlate them and say, you calculate the risk for CIN 3 plus, not 2. 2 is again transitory. It can clear off. When we know CIN 1, 2, it can clear off majority of them. So CIN 3 plus risk categorization is that if their risk is more than 4%, immediately it warrants for a colposcopy, not even colposcopy, straight away some treatment they say. That is the risk scoring by the ASCCP, which has been introduced in 2021. I think they have introduced. So these things, if we remember, unnecessary colposcopes and unnecessary treatment, especially, we will not be giving to the patient. Thank you, Priya.
That's exactly what, madam, we really need to give a take-home message that HPV, having an HPV, don't fear. Because HPV positive, what next makes the world collapse for the patients. The doctors really also get a lot of stressed when they see HPV positive on the report. And the patients look to the doctor to say, now what next? And because of lot of ambiguity in understanding how to go about with this, they land up into unnecessary hysterectomies. Now, the thing is, I always say this to all our candidates, even if you do an hysterectomy, HPV is going to remain onto the vagina. Are you going to remove vagina too? No. So there are methodologies of how to take it up. And HPV positive, as Sundari madam fantastically said, you are putting a genotyping if it is 16 and 18. Now understand one thing, dear friends, when we talked about CIN 3, madam just mentioned CIN 3 plus risk. We are more worried that the patient should not go into a cancer. CIN 2 can also regress, CIN 1 definitely can regress. Now, so the understanding is if it is 16 and 18, let her go for a colposcopy. If it is added with an HSIL, that means the CIN 3 plus risk is above, say, 60%. So having above 60% of risk of becoming CIN 3+, there is a methodology of doing expedite treatment. You can do a treatment, but only if, again, you should be having a good cytopathologist, giving your results of cytology also. Don't get swayed away. What is happening is there is a lot of swaying away. Otherwise, do a colposcopy, take a good punch. Take a good punch. Another thing, if your colposcopy also has got limitations, even with the best of the best hands, Dr. Sanger used to say this, that even with the best hands, the colposcopic sensitivity is set to the tune of 80%. You might miss out. So what you do is taking a biopsy, best thing, take a biopsy, 2-quadrant biopsy can be taken up. If you're not understanding colposcopy in the best fashion, put a VIA, as madam just mentioned. VIA, you have to know the parameters. Metaplasia has got 8 different parameters by which you can understand that this need not be a lesion. Metaplasia is also VI positive. But then you understand by understanding it's a thin, it is shiny, it is translucent, doesn't have a set geographical pattern. It can just arise anywhere. And again, it appears and disappears fast. It's cloudy. It's like, it's merging with the rest of the tissues. So finger-like, fawn-like. These are the VIAs, which are the metaplasias, which are physiological. Again, I always keep on getting, even today, even now, I get a lot of messages. Madam, my this thing was metaplasia. Should I go ahead? What do I do? Please understand, dear friends, metaplasia is a physiological condition coming from single columnar epithelium to multiple squamous epithelium. So don't worry. It is just physiological. And Dr. Bharti also mentioned very clearly, post-menopausal spotting, bleeding, do an endocervical curette, do a endometrial biopsy too. So these are very important things to understand. Do not get scared because she is an HPV. Many HPVs regresses. Another thing, the other day I was with NDTV and they said there was a lot of this, with the Entagi and all that, no? So there was a nice discussion which went ahead with HPV. And the discussion was, please de-link HPV to sexuality.
Yes.
HPV can be positive with a monogamous relationship too. That doesn't mean that, having an HPV means a cancer or an HPV means polygamous relationship. No. HPV is a very common virus. Having an HPV, we have the protocols. We had brought GCPR. Foxy GCPR came out very well in 2023 during my time as Onco Committee Chair. If HPV is positive, you triage it with genotyping. Genotyping 16-18, as Madam superbly said, 16-18 do a colposcopy. Non-16-18, triage it with a PAP test. If the PAP is showing NILM, you have an adequate time of 2 years. Just wait for 2 years, repeat an HPV. Superb. Or you do not have the facility for triaging, or the patient is not you can do a VIA simple. You can do a colposcopy if you have. So this type of triaging methods are very important, friends. The purpose of doing this case-based discussions are, we don't want things to go berserk, which is happening these days. And we don't want excessive hysterectomies to occur or not doing at all. Either we do over treatment or we actually don't see at all. And we say nothing will happen. Now, in this case, if you see, which I had brought, now this case is an HSIL. She is a CIN2. She is a PAP HSIL. And if the colposcopy reading wasn't adequate enough, it was inside, you do have to have the colposcopic view to understand this case. This could be easily missed out. No problem. It could be easily missed out. So biopsy is very important. So that's what I wanted to get from this case. And Dr. Sundari, Dr. Bharti, anything else you want to tell to our viewers? Most welcome.
No, as you rightly said, Dr. Priya, I think at least a VIA. Everybody may not be a colposcopist, but a speculum examination, a VIA, and a biopsy could give us adequate information to manage them. and avoid unnecessary treatment. I think that should be the take home.
Yes. The last word from Dr. Sundari, madam.
Don't treat pap smear reports. Try to have a biopsy. See, histopathology is the gold standard for planning any treatment. So pap smear has come HSIL, I'll treat the patient, no way. So we have to have a gold standard test that is a histopathology. Either you do by VIA biopsy or you do by colposcopy. But though WHO said that screen and treat and then see and treat again, we'll take a biopsy colposcopically and treat at the same time. Screen and treat is we are limiting it only to the community-based screenings where they don't come back there. Otherwise, in your practices, if your patients are in a private practice or institutional practice, when we are doing the pap smear reports, we should not treat. We must have triage and we must have a authentic report by the histopathology. Either you do by VIA biopsy or you do by colposcopy biopsy, whatever it is, you do. And one more thing is, please don't do a blind cervical biopsy.
Yes.
It has no role. Please don't do cervical biopsy. You look at the cervix, it looks very normal. When I put a colposcope and put acetic acid, there's a huge lesion coming up. So by just a naked eye, we'll not be able to know where to take a biopsy. At least put acetic acid. You can keep a 5% acetic acid, which is nothing but a vinegar. You dilute it into 5% and keep it in your, in a OPD, put it there, wait for 1 minute, and then you take a biopsy. If not, the colposcopically directed. No blind biopsy on cervix, treatment of cervix. Any screening method you have done, don't treat except the VIA, which has been advocated by the WHO, screen and treat. Otherwise, always have the authentic report of. One more thing which is important is to have a report by HPV, histopathology report is a later to follow. If you just see and treat, you don't know what is the severity of the lesion, we don't know. We are seeing after hysterectomies also, we are seeing the what recurrences. If the HPV is positive. So please just don't, wherever there's a possibility, take a biopsy, guided biopsy, and then properly treat them. CIN, we don't need to treat them. Now the histopathology also is being terminated. Terminology is LSIL and HSIL. If it is LSIL, you don't need to treat them, just follow them up. If they are persistently positive, then simple method of ablation can be done. If it is HSIL, then you have to know what is our chance of progressing. For that, again, a molecular test has to be done now, P16. If the P16 they are positive, yes, they are going to high grade lesion. That CIN2, histopathologist has to give HSIL favoring CIN2 or favoring CIN3. They have to give, but still our histopathologists are not yet oriented to that. They will take time. Meanwhile, what we could do if they give us HSIL, if patient can afford, we get a P16. If it is positive, you can do ablative method there itself. Or if the lesion is big in such people, I think it's better you do colposcopy. Lesion is big and see the transformation zone, you can do excision. But if it is CIN3, always CIN3, HSIL favoring CIN3, always it's excisional procedure. Simple things we remember. CIN2, you can be ablative or excisional depending on the, again, high risk factor for her. CIN1, whatever it is, even HPV DNA positive, it is CIN1, it has come after your evaluation. Just follow her up. It will regress. Many of them it will regress because we have been seeing it for many, many decades. So that's this one, how to just go about with the simple thing. So low grade lesions follow up, high grade lesions treat, CIN3, excisional always, CIN2, it can be ablation or excision. That's all it is. The whole gist of it is only that much.
Yes. So thank you, madam. It was truly wonderful because this type of small case discussions truly matters for all the practicing gynecologists, and how to take it up makes a lot of difference, hell lot of difference of case management. Thank you very much. Over to Dr. Ananya. If there is any questions from
Two more panelists are there, no?
audience.
You have?
Dr. Vidya couldn't join because she's having a
Oh.
case. Yeah,
Okay,
she
okay.
just.
Jatubi couldn't join.
Yes, yes.
There is a question in the chat box. What to do if PAP report is ascus? I think cleared it.
Okay. So, like PAP is ascus, you don't have to worry. Number one is you can put up an HPV triage. And if the PAP ascus and HPV negative, just nothing to do. Call her up after a year, repeat her PAP test. No need to even repeat an HPV. But if the PAP is ascus and HPV is positive, then you have to go for a colposcopy. So that's the simple understanding with PAP ascus. Ascus means atypical squamous cell of undetermined significance. That's the main thing. Only if the PAP is LCL and above directly, you can go in for a colposcopy. If you are colposcopy based, cytology based screening person, as many of the doctors in our country are still cytology based screening. So this is how you can take it up. Yes.
I think we can conclude this session. Thank you, experts, for such an enthusiastic and comprehensive discussion. And we can move to the vote of thanks now.